Hey, Mr. J. So this is our hip eval video for AIM 3. I'm Tyler.
I'm John.
Do I have consent to touch you throughout this video?
Yes. And do I have consent to touch you throughout this video?
Yes. So we were given the evens throughout the evaluation. So we're going to start with complete history. So we're going to start with where does it hurt?
So we have a 22-year-old Division I college hockey player, and he felt a sudden pain in the front of his right hip.
This problem has been going on for around a week or two. He came in saying about how it's like a knife pain more than anything else. There is slight throbbing as well.
All right, so now we're going to be doing the running palpation. So we're going to be starting with the iliac crest. So you're going to find the ASIS here, and then you're just going to be palpating, moving all along the iliac crest here and down to the PSIS. And then for the SI joints, you can palpate them right here. There are the little dimples in the back, you can see. And then if I'm gonna ask Tyler to bend over a little bit, you can really find a little gap right here. You can just put your two fingers in here, and that's where the SI joint is. And then for the ischiotuberosity, I'm gonna have Tyler lay down, and I'm gonna have him bring his right knee to his chest. And I'm gonna be pushing right here, and ischiotuberosity is so right there.
Okay, Mr. J, so now we're on to fracture testing. We were not presented with palpation, but we would palpate as well to make sure there's no fracture. But if then we will go on to the next test, which is I would ask him to lay down, and I would see if his leg lengths are the same, which they are. But if you rotate the one leg out and it is shorter, as seen here, this could be a positive indication of a fracture as well. We would obviously need to do more testing like x-ray or MRI to get a full evaluation and really see if it is fractured or not.
All right, so now we're going to be doing range of motion. First up, we have extension. So I'm going to have Tyler here laying on his stomach. I'm going to line the axis of the goniometer up with his greater trochanter. Stabilize that. And then for the movable leather arm, I'm going to line it up with his femur, and I'm going to have Tyler raise his foot. And keep it in line. And Tyler measured about 30 degrees of motion.
Okay, Mr. J, now we're on to range of motion testing of the adduction of the hip, adduction of the hip. So I will line it up with his ASIS right here. Yep. And then I will line it up with his other ASIS over here, and then take the movable lever arm and line it up with his femur. And then I will ask him to move this leg over the other leg, and I will measure the difference. Take it up over. There you go. And I got around 18 degrees movement. So this is testing range of motion of external rotation of the hip. So I will line up the external rotation with his kneecap, and then he will hold the stable lever arm, and then I'll ask him to rotate his foot inward, and I will follow. And he got 25 degrees of rotation.
There you go.
Okay, so now, Mr. J, we're on to soft tissue palpation or muscle palpation. So I'm going to start with the gracilis. So the gracilis, its origin is the pubic symphysis and the inferior ramus of the pubic bone. So the gracilis starts up in here and then runs down through here. Its insertion is the proximal, interior, medial, tibial flare, and then the action is knee flexion, interior tibial rotation, and hip adduction. Its innervation is the obturator nerve. Now we're on to the pectineus, where the pectineus runs in through here, and it's deep, so you really can't palpate it. The origin is the superior pubis symphysis. The innervation is the obturator nerve. The action is hip adduction, and the insertion is the pectineal line of the femur. Next, we're on to the abductor longus. The adductor longus runs in through here. Its origin is the anterior body of the pubis. Its insertion is the middle third of the linea asperae. Its action is adduction of the hip, lateral rotation of the hip, and it also flexes the hip. And its innervation is the obturator nerve roots L2, L3, and L4. Now we're on to the adductor brevis. The brevis, it is up higher and it runs down through here. This one, its origin is the anterior inferior pubic ramus. Its insertion is the pectineal line. Its action, it adducts the hip, lateral rotation of the hip, and flexes the hip. Its innervation is the obturator nerve L2, L3, and L4 roots. And then the last one we will cover is the adductor magnus. The magnus runs in through here. And its origin is the ischiotubik ramus. Its insertion is the posterior aspect of the proximal femur. Its action is thigh adduction and external rotation. And its innervation is the obturator nerve roots L2, L3, and L4.
All right, Mr. J, so we're doing more muscle palpation. So we're going to start with the tensor fasciae latae. So the origin is going to be the ASIS, just up here. And then you're going to just run down, palpate to about here where it turns into the IT band, and that goes down all the way down to the knee. And then the origin is obviously, as I said, the ASIS, the outer edge of the iliac crest. The insertion is the iliotibial band. The action is hip abduction and hip medial rotation along with hip flexion. And then the innervation is the superior gluteal nerve L4, L5, S1. Next up, we have the gluteus maximus. So the origin is the posterior surface of the ilium, posterior surface of the iliac crest, and just runs down this way. And then the insertion is the fasciae latae of the iliotibial tract and the upper posterior surface of the femur. The action is hip extension and lateral rotation along with hip abduction. And then the innervation is the quadratus femoris branch L5, S1. And then last up, we have the sartorius. So it starts at the ASIS and runs all the way down here to the knee. The origin, as I said, is the ASIS. The insertion is the superomedial tibia. The action is flexion, lateral rotation, and flexion of the knee. And then the innervation is the femoral nerve L2, L3, L4. All right, Mr. J, so next up we have the palpation of the sciatic nerve. So I'm going to ask Tyler to take his right knee, lift it up to his chest. I'm going to find the ischiotuberosity, put my other hand on the greater trochanter, and extend. It's a little hard to see, but the nerve runs right through where my thumbs meet. So it's right here. Let's see if I can be right in this area. Greater trochanter, ischiotuberosity, and then the sciatic nerve will run right here.
So now we are on to the sacroiliac ligaments palpation. We are not able to do this because of the muscle and other body parts that are present over these ligaments, but the main purpose for these ligaments is to connect the sacrum and the iliac so they can work together and move together. Okay, Mr. J, so this is muscle testing. First, we're going to cover the rectus femoris. So I'm going to ask him to have his testing knee off the table, his off knee bent, and then I'm going to ask him to lay back. So for the active test, I'm going to ask him to do knee extension first, and then hip flexion. Okay. So active test, please. Perfect. Okay. And then next we're going to do active resistance. So I'm going to place my hand here and here, and I'm going to ask him to do knee extension. Good. And perfect. Okay. And now on to the break test. So I'm going to count to 5. I'll tell him this as well. So I'm going to place my hand here and here. I'm going to set him in the middle of the range of motion. Then I'm going to apply pressure here and here, and he's going to resist it for 5 seconds. Ready, go. 2, 3, 4, 5. Good. And he tested well there.
All right, Mr. J, so now we're doing the muscle testing for the tensor fasciae latae. So I'm going to have my patient lying on the side on the table. I'm gonna have his leg back and off the table to get into a stretch. And then I'm going to stabilize with my hand on the pelvis and then one hand on the leg. However, I'm going to ask him to do his active range of motion. So can you just bring your foot to the ceiling, no resistance. Okay, and then now I'm going to do active resistive. So I'm going to put my hand on his pelvis, my other hand on his leg, and resist through his full range of motion. Good, and then for the break test, I'm going to put his leg in a halfway position, still stabilizing his pelvis, hand on the leg. I'm going to be pushing down for 5 seconds. 1, 2, 3, 4, 5. And he passed all of the tests. All right, Mr. J, so now we're doing the hamstring muscle testing. So I'm going to have my patient lying on his stomach. And I'm going to resist hip extension and knee flexion with my hand on the posterior upper thigh and my other hand on the ankle. Before I do that, I'm going to ask him to go through his full active range of motion. So can you just bring your ankle back? Okay, and then now this is active resistive. So hand on upper thigh, posterior upper thigh, other hand on his ankle, and I'm going to resist the entire range of the motion. Okay, and then now for the break test, I'm going to put Tyler in a halfway position. I'm going to stabilize with my hand on his posterior upper thigh and then on his ankle, and then I'm going to push down for 5 seconds, and he's going to resist the pressure. 2, 3, 4, 5. And he passed all hamstring muscle testing.
We are now on to muscle testing of the gluteus minimus. So I'm going to ask my patient to sit off the table with knees off. I'm going to ask him to take his foot out to the side. So I'm going to ask him to actively do it first. Good. Okay, then I'm going to actively resist. So I'm going to place my hand here and hand here. Go. Perfect. Okay, now I'm going to do a break test. I'm going to set him in the middle of his range of motion, and I'm going to do it for 5 seconds. You ready? Go. 1, 2, 3, 4, 5. Good. Strength was there and range of motion was there. Positive test. Good. So this is muscle testing. We're on to the sartorius muscle, which is the Taylor test. So I'm going to ask my patient to lay back, put this leg off, leg up, and then I'm going to ask him to perform a motion of this nature. So he's going to go up and put his leg across. So that's for active motion. Could you please do that? Good. Okay. Now active resistive. So I'm going to place my hand under his ankle and up here above the thigh, and I'm going to resist his motion through. So please go. Okay, good. And then break test, I'm going to put him in the middle for 5 seconds and resist his motion. And you're going to hold me. Go. 1, 2, 3, 4, 5. Good.
All right, Mr. J, so now we're on to special testing. First up, we have the Ober's test. So I'm going to have my patient lying on the side. His right knee is going to be flexed at 45-degree angle. And then I'm going to take his left leg, bring it back into hip flexion, and then stabilize the pelvis. And I'm going to slowly drop his leg down and get the stretch on the iliotibial band. And then a positive test would be for maximal or minimal tightness. And for maximal tightness, the leg is unable to adduct to horizontal. Minimal tightness, the femur adducts to horizontal. And then a normal test would be the femur adducts past the horizontal. So we're all good.
Okay, Mr. J, so this is the next special test. We are on to the hip scouring test. So I'm going to ask my patient to lay supine on the table. I'm going to ask him to bring his knee into full flexion and his hip into full flexion. I'm going to put downward pressure on his femur to put pressure on the joint, and then I'm going to internally and externally rotate his femur. A positive test here would be a reduction of pain or symptoms in the hip that were being presented. Okay, so now we're on to the true leg length test. So for this, we're going to split it up into two. So I'm going to measure the length of the femur and the length of the tibia. So we're going to start with the greater trochanter. Find the greater trochanter, which is right here. You're going to place the ruler on that and take it down to the joint space in your knee, which is 22 centimeters. Or no, that would be inches, 22 inches. And then we're going to go to the medial tibial head, which is right here. And then we're going to run it down to the medial malleolus, which is 17 inches. So 22 plus 17 is 39 inches. We would compare these bilaterally, but for the sake of the video, we will not today, but in the test, in a clinical setting, we would compare bilaterally to see the difference in leg length to determine if they are different. Okay, Mr. J, now we're on to functional testing. So we would functionally test our athlete. We would ask him to walk. We would ask him to do 5 deep knee bends. And we'd also ask him to run forward and backwards. And we would evaluate how he does these actions to further tell us if there are any hip problems or implications that we haven't seen.
And then to finish up for the video, we have our hypothetical scenario. So we have Tyler, and he is a 22-year-old Division I college ice hockey player who trains about 5 to 6 times per week. And he came in complaining he felt a sharp, sudden pain in the front of his right hip while skating to chase the puck during a game. He continued playing but felt increased tightness and pain later that evening. The pain persisted, especially during skating strides and quick direction changes. He has been icing and stretching at home, but has had minimal improvement. His past medical history, he had a mild groin strain last season, but he has no history of hip or back injuries, and he's currently on no medications. The physical exam findings at the doctor, he had pain with resisted hip flexion, tenderness over the iliopsoas region, and slight swelling over the anterior hip. He has normal passive hip range of motion, but he has discomfort at the end of his range. And he had a positive Thomas test, which assesses hip flexor tightness. He is assessed to have a grade 2 right hip flexor strain, and the plan of action is to price, protect, rest, ice, elevate, compression, and elevation. Short-term activity modification, gradual rehab on hip flexor mobility and strengthening, and then physical therapy if nothing else really works. And then he's cleared to return to play once he is pain-free with full strength and full range of motion with no discomfort.
Thank you very much.
Thanks, Mr. J.